Emergency management of intracranial hemorrhage. Close attention should be paid to airway management because a reduction in the level of consciousness is common and often progressive. The initial blood pressure should be maintained until the results of the CT scan are reviewed and demonstrate ICH. A higher blood pressure should promote hematoma expansion, but it remains unclear if lowering of blood pressure reduces hematoma growth. Recent clinical trials have shown that systolic blood pressure, SBP, can be safely lowered acutely and rapidly to 140 mmHg in patients with spontaneous ICH whose initial SBP was 150 to 220 mmHg. The Interact-2 trial was a large phase 3 clinical trial to address the effect of acute blood pressure lowering on ICH functional outcome. Interact-2 randomized patients with spontaneous ICH within 6H of onset and a baseline SBP of 150 to 220 mmHg to two different SBP targets, 140 and 180 mmHg. In those with the target SBP 140 mmHg, 52% had an outcome of death or major disability at 90 days compared with 55.6% of those with a target SBP 180 mmHg, p equals 0.06. There was a significant shift to improved outcomes in the lower blood pressure arm, whereas both groups had a similar mortality. Attach-2 was a similarly designed clinical trial that assessed the same blood pressure targets but demonstrated no difference in outcome between groups. Current US and European guidelines emphasize that blood pressure lowering to a target SBP is likely safe and possibly beneficial. In patients who have higher SBP on presentation or who are deeply comatose with possible elevated intracranial pressure, ICP, it is unclear whether these clinical trial results apply. In patients who have ICP monitors in place, current recommendations are that maintaining the cerebral perfusion pressure, mean arterial pressure MAP minus ICP, at 50 to 70 mmHg is reasonable, depending on the individual patient's cerebral autoregulation status. Blood pressure should be lowered with non-vasodilating 4 drugs such as nicardipine, labetalol, or esmolol. Patients with cerebellar hemorrhages with depressed mental status or radiographic evidence of hydrocephalus should undergo urgent neurosurgical evaluation. These patients require close monitoring because they can deteriorate rapidly. Based on the clinical examination and CT findings, further imaging studies may be necessary, including MRI or conventional X-ray angiography. Stuporous or comatose patients with clinical and imaging signs of herniation are generally treated presumptively for elevated ICP with tracheal intubation and sedation, administration of osmotic diuretics such as mannitol or hypertonic saline, and elevation of the head of the bed. Surgical consultation is obtained. Reversal of coagulopathy and consideration of surgical evacuation of the hematoma are two other principal aspects of initial emergency management.